Thank you. Thank you, Christina. I enjoyed your talk about the technicalities. I hope I have more luck with this presentation now than before, because I would like the slides to run. I'm going to talk to you about staging and characterization and detection of liver tumors with ultrasound. First, I'd like to tell you where I come from. I come from Denmark. This is my backyard. It's flat. It's green. We are connected to Sweden by a bridge, and actually that bridge is the highest point in Denmark. So Denmark is a very flat country. The highest point is 204 meters. Denmark is a small country on top of Europe, only about 5 million people, 43,000 square kilometers. That is maybe half the size of Sao Paulo state. So Brazil is almost 200 times bigger than Denmark, and you have a population that is almost 40 times bigger. So we are very small compared to Brazil. Of course, Brazil is the 5th largest country in the world. Well, my country is small, but my family is large. And also, maybe you don't know, but Denmark is more than just Denmark. Denmark is actually also Greenland. Greenland is a part of the Danish kingdom, and Greenland is 2.2 million square kilometers, the largest chunk of ice on Earth, except for Antarctica, of course. But this is an island, and you have beautiful sculptures of ice if you take a boat drive up there. And Denmark is also Faroe Islands. The Faroe Islands is a small group of islands between Norway and Iceland. And why am I telling you this? Because this is where I come from. This is my dad came from there. So my name, Nolsø, is the name of the island in front of the capital. This is a small country. It's part of Denmark, only 45,000 people. My father was one of them. They have more sheep than they have people, and the sheep do not respect cars. They have millions of beautiful birds. Anyway, let's go to diagnosis of liver tumors with CS. Do you see the liver tumors? I'm sure you can see there is some irregularity. You put contrast, now you see it much easier. Here we run in parallel. These are old slides because just to show you that you don't need the fancy stuff. Without contrast, with contrast, you see much more. Sometimes, let's see. Okay, sometimes if you have not used contrast, you cannot see it. So this lesion you cannot find here. This is an unknown primary cancer. We took a biopsy, and the biopsy turned out that this was actually a colorectal metastasis. So the patient, we got the diagnosis of not only the metastasis, but also the primary. So what is it? If you have a lesion like this, you cannot see. How good are we at that with ultrasound? How much do we see more with ultrasound contrast than without ultrasound contrast? Well, first of all, you have to realize that the sensitivity using ultrasound contrast increases the study with up to 40%. So here are some studies showing ultrasound detection of metastasis with contrast and without contrast. So you can see between 15 and 40% you see more. So you definitely see more lesions, and sometimes you see lesions that you could not even see without. What if we compare to CT, and what if we compare to MRI? How good are we? Well, ultrasound is comparable. It is significantly better than without contrast, but if you compare to CT, it is just as good. Here are some studies showing that some groups found that CT was better. CT is the yellow. Some group found that CUS was better. But if you compare a bigger number of articles, you come out with the result that in the hands of skilled users, contrast ultrasound is just as good as contrast CT and also as contrast MRI. These are two studies that I would go in a little details with later, but just want to show you here that the sensitivity and specificity of CUS compared to CT and MRI was the same. They are in the around between 80 and 90, and it is the same whether you CT or MRI. Maybe you don't see the same lesion with CT as with CS, but the specificity overall is just as good. So now you have found it, you have detected it. What about to characterize it? Can you characterize a lesion with CS? Well, whenever you see a lesion, like here, there is a lesion, the first question I have is this benign or is it malignant? And my next question would be, if it is malignant, what kind of malignancy? How would I get that diagnosis? Well, I could use SEUS maybe I need a biopsy, maybe I even need a SEUS guided biopsy. So this is a SEUS guided biopsy. And here we have a lesion, incidental lesion found on a patient coming for, just pain in the abdomen. We found a huge lesion. Any of you have a guess? You might guess what it is, but what do we do next? In the old days, we would use a biopsy maybe. Today, I would use contrast agent, and you can see how it is filling in from the center, and there is a scar in the center, so this diagnosis is clear. Also, because in the late phase, it has no washout, so it's a benign lesion, and there is no doubt that this is an FNH. So we don't need a biopsy. This is what I explained to you, what we have put in the guidelines. Sustained enhancement, no washout, benign lesion. You can characterize it in the arterial phase. The recommended indication for characterization of focal liver lesions are incidental findings on routine ultrasound. Lesions that are suspected and detected with other modalities, for instance, CT and MRI. I get many referrals that this patient had a lesion seen on CT or MRI. Can you tell us what it is? So we do contrast agents. Maybe we cannot even do CT or MRI because of malfunction of the liver or the kidney, and then we can do CS. Maybe we have taken biopsies before and it's inconclusive. So remember this algorithm. If you remember nothing else, just remember this. If it is not wash out, if it is enhancing also in the late phase, it is benign. Then we can afterwards discuss what kind of benign it is. Hemangioma, FNH, adenoma. But if it is enhancing in the late phase, it is benign. If it washes out, if it becomes black in late phase, it is bad. So watch out for wash out. Watch out for wash out. If it washes out, if it turns black, it is bad. If it stays enhancing or white, it is good. So I want to illustrate it with a case. This case we found two incidental findings. One is white, one is black. One is hyperechoic, one is hypoechoic. I guess you know what it is already. Maybe you do. My guess is this is a hemangioma, this is a metastasis. But it could be different. In the old days, I would take biopsies. What do I do now? And which one is good and one is bad? I know that because I get the diagnosis. Here we have arterial phase. You can see this white one, it has globular filling in from the periphery. This black lesion is filling in diffusely from the center in the arterial phase. Already now we have a clue. This must be hemangioma, maybe because it's filling in from the periphery. This could be anything, but let's see. Then in the portal phase, you can see this, what we expect to be hemangioma is filling in slowly, and the other one is starting to wash out. And in the late phase, you can see now this lesion that was hypoechoic on the fundamental, now it has totally washed out and it's also dark on the serous. So this is definitely not a good lesion. This is a bad lesion and this is a metastasis. The other one is now filling in. It has not filled totally in, but you can expect many hemangiomas will not do that. But this is a benign lesion. So now we have a diagnosis. Two lesions, one is benign, that's a hemangioma. The other one is malignant. It could be a metastasis, it could be a primary. We don't know. How do we get that answer? Well, I took a biopsy and the biopsy showed me there was a colorectal metastasis. So there's this multi-center study from Germany. It's called the Degum Multi-Trial Center. It's a very good study. They had almost 1,400 patients, And they were looking at, can we differentiate between benign and malignant with serous? How good are we at that? So look at, they had PV positive and PV negative about 95%. That is very, very good. So a very high diagnostic accuracy. So in other words, if you have a typical serous study, you can reliably differentiate between typical benign and malignant lesion. And the positive and negative predictive value are around 95%. Of course, there are false negative, false positive, they are everywhere, but they are rare. What you cannot do, you cannot differentiate between different kinds of malignancies. So you cannot tell where this cancer come from. Now, is that so special? My question is, can you do, can CT or MRI, can they tell you where the cancer came from? Not if you only have the liver. You need a biopsy. So here we have 3 different patients. They had 1 metastasis each. One there, one there, one there. Where is the primary cancer? You don't know, I don't know. We took biopsies, we found out bladder cancer, pulmonary cancer, kidney cancer. So serous and CT and MRI, no difference with that respect. You cannot tell where the primary came from, except if you have a study that shows a lesion somewhere else. So the specificity and sensitivity are very good, except if we have patients that are very fat or have fatty liver infiltration. So if you have a study like this where you have densely fatty liver and you have a poor fundamental study, you can just expect that your serous study will become worse. So that is one limitation. And sometimes you have atypical enhancement pattern. In those cases, you need to go on either CT or MRI to try them to characterize it, or maybe you take a biopsy depending on what are you dealing with. Now, let's look a little bit on different kinds, just a few different entities. Here are benign, here are malignant. How do you separate that? Remember, you look, if there is sustained enhancement, it's benign. If there is not sustained enhancement, it is malignant. And this is only the case if you have a non-cirrhotic liver. If you have a cirrhotic liver, you use another algorithm. When do we need biopsy? Well, remember, if it stays white, if it has enhancement, it's good. If it does wash out, it's bad. Here, I want to show you an adenoma. Adenoma is a rare condition, but it is benign and it will have sustained enhancement. Now, this was a 30-year-old lady that came to us to rule out gallstones. We found this incidental lesion. We injected contrast agent. You can see in the arterial phase, it is taking quickly enhancement. It is hypervascular. It is a little patchy, but it is hypervascular. In the late phase, it stays still hyperenhancing, not washing out. So it's benign. It is benign because she did not have a cirrhosis. So do we need a biopsy? I expect this to be an adenoma because it is not an FNH, it's not a hemangioma, it must be an adenoma. So do I take a biopsy? In this case, I take a biopsy, yes, because it is larger than 5 centimeter and then there is a higher risk of malignancy. So even I expect it to be benign, I take a biopsy. And I know it could be just a small area malignant, so maybe I miss a malignancy, but I would take a biopsy. Now let's take, and this was benign. Let's look at some other entities that do not have sustained enhancement. They wash out. It could be metastasis, it could be HCC, it could be a CCC, cholangiocarcinoma. Here is a cholangiocarcinoma, a Klatskin tumor. They can be very difficult to diagnose. You know that. Sometimes you can barely see them. Now here's a case. There's an echo-rich area in the center of the liver. We give contrast. It enhances quickly, so there is arterial enhancement. On the late phase, you can see it washes out. It's not very clearly washed out, but there is some washout. We went ahead and we took a biopsy, a fine needle aspiration, and this turned out to be a Klatskin tumor, a cholangiocarcinoma. What about HCCs, hepatocellular carcinomas? You know, they are of course more frequent than CCCs. There are 2 kinds. We have the HCC that we discover de novo in a non-cirrhotic liver. This is very rare, but we see those. Most of the HCC we discover are in a cirrhotic liver. In a cirrhotic liver, you have to know, maybe you have a highly differentiated HCC and maybe this will not wash out. So if you have in a cirrhotic liver under surveillance, if you discover a new lesion, and if you have hyperenhancement in the arterial phase, and it's a newly discovered lesion, even though there is isoenhancement in the portal and late phase, it is very suspicious of being an HCC. So this is the only case you have enhancing tumor being malignant. Cirrhotic liver on surveillance, new lesion. If it is still enhancing, it could be malignant. So here's a case of an HCC in cirrhosis. You see the lesion, and you can also see it is hyperenhancing in the arterial phase and in the late phase. If I can, yeah, in the late phase, you can see it is washing out. This is not the lesion, this is a cyst. But the lesion is here, it's washing out, not enormous washout, but it's washing out. And that is very suspicious. This is an HCC. You don't need a biopsy. But sometimes, if you have enhancement in the late phase on a cirrhotic liver, it could still be. So here's a lesion in a newly discovered lesion in a cirrhotic surveillance. This is a cyst. This is a lesion. We give contrast agents, and this case I actually use sinusoid. And you can see the lesion is here. It's barely seen in here, so it is still enhancing after 30 minutes. But remember, 15% of HCCs in cirrhotic liver still enhances there because they are highly differentiated. How do you get the diagnosis? Well, there's only one way to do it, and that is to take a biopsy. What about evidence for this? How good evidence do we have? We have multi-center studies, we have meta-analysis and systematic reviews. Now, the difference between the two latter is the systematic reviews is just looking at a lot of articles. In the meta studies, you try to make a summarized figure like the sensitivity. We have a total of 11 multi-center articles. They all tell us the same story. These are the biggest the biggest systematic reviews, and I just want to deal a little bit with this. One of them from the German study in 2013, they say, SIOS should be the first method of choice in the diagnostic workup of focal liver lesion if B mode and double ultrasound are not conclusive. Now, they looked at 45 studies with a total of more than 8,000 liver lesions, and this is their conclusion. This is also what the guidelines is based on. The other one is the biggest study, and the one I mentioned before. They had looked at 850 studies, and it's a huge document, 390 pages. They looked at 3 different populations. They wanted to see how good are we to detect, to characterize, and to look for new tumors on cirrhosis surveillance. So, in characterization of focal liver lesions detected on ultrasound surveillance of cirrhosis, in detection of liver metastasis in patients with colorectal cancer, and in characterization of incidentally detected focal lesions, SIOS is just as good as CT and MRI. SonoView SIOS provides similar diagnostic performance to other imaging modalities as CT and MRI for these 3 main indications, which are the main indication we use for focal liver lesion. Now, there's one other important point in this article. That is that actually SIOS is also cost effective. It is, I tell you, in a right setup, it is even cheaper. SIOS is cheaper than both CT and MRI. And it is just has the same sensitivity and specificity. The only thing it takes is that you take the time to learn it. It is a learning curve. It takes time, but it's a very good thing. And their conclusion, I think, is very important. If the main use of liver imaging is considered to be rapid rule out of malignancy, equivalent diagnostic performance may be sufficient for SonoView SIOS to be preferred over other imaging modalities. In other words, they are a little precautious, but they are saying, if this is what you are looking out to rule out malignancy, you should go with SIOS before CT and MRI. And they also say, and this is very important, a potential advantage of using SonoView SIOS would be the option of completing the assessment at the same time as the initial study. In other words, if you refer a patient for CT and MRI, when do you get the answer? Well, if you're the radiologist, you have the answer immediately. But if you're the referral doctor, you might have to wait 1 or 2 weeks because it takes some time. But if you get the ultrasound study, you have the diagnosis immediately after. Okay, what about CUs and staging? Is CUs or is ultrasound good for staging? Well, no. Staging of cancer, you need whole body imaging, and usually ultrasound is not very good for that. So ultrasound, first of all, would never pick up small notches in the lungs, but also we do not get the big picture. So for staging, CUs is not, and ultrasound generally is not the best.
Could you use the sonogram, or you have to refer to the physician and then they ask? You have the freedom to do it.
If I get a patient, usually, if we get a patient in an ultrasound unit, we don't have to ask. We just go ahead and give the contrast agent. In Denmark, medicine is totally socialized. No patient pays. Patient is referred to the hospital. The doctors decide what to do. Patient comes to me now. I don't work in radiology right now. I'm a radiologist, but I work in surgical department. But even if I worked in radiology and a patient came, I would have the decision if I should use CUs. Very often, I would also take the decision myself if I should take a biopsy. So the patient comes to me now in surgical division. They expect that. Many patients are referred from oncology. If I think I need a biopsy to get, if the CUs does not answer my question, I will take a biopsy. Unless I know, because we have also what is called multidisciplinary, multidisciplinary conferences. So I know what they would say. So if it is a patient that would be candidate for liver resection, I will not take a biopsy. But if I expect that they would have a biopsy, I take the biopsy, because otherwise the patient should wait another week or 2.
Yes.